Hello friends, today I am starting a talk on an important congenital heart disease, cyanotic heart disease, that is tetralogy of Fallot. So friends, this is a very important topic in MBBS and MD exams, and today's purpose of the talk is to have a core understanding of what is tetralogy of Fallot. It has got four components: pulmonary stenosis, VSD, overriding of aorta, and right ventricular hypertrophy. It is the most common cyanotic congenital heart disease, although the most common congenital heart disease is VSD. But among the cyanotic heart diseases, it is the most common and frequently associated with syndromes like Down syndrome or Digeot syndrome. Roughly 10% of the congenital heart disease is because of tetralogy of Fallot. So you can compare here the normal cardiac structure with the TOF structure. In the normal circumstances, the blood from the right atrium goes to the right ventricle and through that to the pulmonary artery, and from lungs it comes to the left atrium, then left ventricle and the aorta and systemic circulation. But here in TOF circuit, the blood is facing a resistance in the pulmonary circuit which is stenosed, and as a result the pressure rises in the right ventricle side, causing the pressure overload on the right ventricle, resulting in hypertrophy, and the blood is shunted out from the ventricular septal defect, plus some of the aorta is overhanging. So this is the critical element in Fallot's physiology. Fallot's physiology is never without pulmonary stenosis, and this is the initiator event which triggers the high pressure development in the right side. So right ventricular hypertrophy ensues and the blood flows from the right circulation to the left sided circulation. The overriding of aorta adds to the problem, and the septal part of the aortic base projects into the right ventricle, so some of the blood goes directly into the aorta also. So ventricular septal defect actually acts as a pressure release valve for the right ventricle, and whenever there is a problem with the right ventricular septum, the shunting causes profound cyanosis. Now there is an important concept of pink TOF and cyanotic TOF. When the child is born, the pulmonary stenosis is very mild obstruction, and the shunt is left to right mostly because of the VSD. But as the baby grows, the pulmonary stenosis becomes more significant, creating an obstructive element, and as a result the shunt comes as right to left because of high pressure development in the right side. So pink TOF is a cyanotic patient presenting mostly as insignificant murmur, and in cyanotic part, when the patient has developed significant stenosis, the patient can be cyanotic or he can be having profound hypercyanotic spells. So we should remember that the degree of right ventricular outflow tract obstruction is the sole determinant of how the patient is going to present to you. So the symptoms are usually starting in infancy in TOF, when the child has grown to certain size. There may be some breathing difficulty felt by the patient because of hypoxia. On examination, you will hear a systolic murmur in the parasternal area and a loud P2. In neonatal period, cyanotic element is not there. One, the pulmonary stenosis is not that significant, and already from the fetal part, the right ventricular pressures and resistance is high. So baby is well adapted to that. And if the child continues to grow into the adulthood, into the childhood, you have effects of hypoxia on the body in the terms of exercise intolerance, easy fatigability, persistent cyanosis, clubbing of the fingers and toes, and frequent episodes of syncope and hypercyanotic spells. So you can appreciate here that the lungs are oligemic because of pulmonary stenosis. The pulmonary bay is highly vacant. The right ventricular hypertrophy creates a boot-shaped appearance, and this is the classical radiograph of tetralogy of Fallot's. On ECG, you will find right axis deviation because of right ventricular hypertrophy. So the most significant element in TOF is hypercyanotic TET spell, and this is triggered by feeding, crying, strenuous activity like defecation, any stress on the body like fever, dehydration, or sudden waking from sleep. The patient suddenly becomes more blue and may appear ashen grey. The child may be so hypoxic that he can lose consciousness, and because at this point there is practically very little blood flowing through the pulmonary segment, there is very little murmur that is audible. So this is the vicious cycle of TET spell that is commonly asked in the exam or the viva. The triggering event causes the spasm of the right ventricular outflow tract and drop in the systemic vascular resistance. Massive right to left shunt occurs through the VSD, resulting in profound hypoxia and acidosis because of anaerobic metabolism. Compensatory hyperventilation takes place, and which also allows more venous blood to enter the thoracic cavity, worsening the cycle further. So this is a very important question asked in the viva or theory exams. So you can summarize that there can be triggers of increased oxygen demand and strenuous activities like crying, exercise, straining on defecation, feeding, crying, etc. Or there could be a metabolic load on the body by dehydration and fever and administration of some certain agents like anesthetics. So children usually learn how to counter this TET spell by squatting. The older children naturally adopt a knee chest position or a squatting episode. So this is a very pet question of examiners, how squatting helps to relieve the TET spell. So you can see here that kinking of the major vessels of the lower limb occurs by squatting and systemic vascular resistance rises. So the left-sided pressures in the heart rise. As a result, the shunting from the right to left decreases. So the cyanosis lessens. So this is the mechanism how squatting helps. In the hospital, if the patient is brought with a cyanotic spell, the first step is to put the patient in knee to chest position, give him oxygen as tolerated, and immediately give some sedative or pain relief. We commonly use morphine or intranasal fentanyl to make the child calm and decrease the right flow obstruction and decrease the hyperventilation episode. Because the child has gone into some acidosis, we give the support by give 10 ml per kg of saline bolus and soda bicarb to counteract the metabolic acidosis. Pharmacologically, we can give beta blockers or vasopressors to counter the right ventricular outflow tract spasm or to increase the systemic resistance by phenylephrine. So you remember this management like a ladder shape approach. On the first ladder, we have calming the infant, bringing the child to knee to chest position, giving oxygen and calling for help. And another is to give analgesia and IV fluid support. And we should remember that if morphine is not available, or IV access is not available, intranasal fentanyl can or midazolam can also be used. Further on, you have to give the saline bolus and soda bicarb, and if the patient is not improving, then you can use phenylephrine to increase the systemic resistance and beta blocker to decrease the right ventricular spasm. Ultimately, the management of TOF is surgical. If the patient's anatomy is not favorable, you go for a palliative shunt. The basic idea is to increase the pulmonary blood flow temporarily, and this can be done by the balloon dilatation of the pulmonary artery or by a shunt from the subclavian trunk to the pulmonary artery, that is Blalock-Taussig Thomas shunt. This is commonly asked in the viva or theory exam about the shunt surgery for TOF. So this results in increased pulmonary blood flow, improves the oxygenation, but shunting still keeps on taking place, and this slightly relieves the hypoxia of the patient. The ultimate answer is the complete intracardiac repair, which takes place in an older child, bigger child, and results in normal hemodynamics ultimately. So naturally, it consists of right ventricular outflow tract reconstruction along with VSD repair. So it restores the circulation to the normal pattern. So this is the detailed blueprint about the complete intracardiac repair. It is being done at a lot of centers now, and the patients are getting benefited by that. Naturally, any major cardiac surgery is associated with long-term complications. So the pulmonary and aortic valve regurgitations can be there. VSD repair can result into conduction blocks, and any operated heart further on is a risk factor for endocarditis. Overall prognosis is good if the patient is managed early, and long-term survival is excellent, and the unrepaired survival is very, very poor. Once operated, the patient remains on cardiac follow-up for complete life, and regular ECGs, echoes, and other cardiac function testing is done. Even successful pregnancies have been recorded with good hemodynamics after surgery. Surgery usually results in some restrictions for very highly competitive stenosis supports only, but normal living there is no restriction. There are some other complications associated with TOF, and this is also one of the core area of viva exam. These are polycythemia and the stroke in the children. So naturally, as the child is hypoxic, the body tries to make more RBCs. Already with the normal hemoglobin, when the more RBCs are formed, this results in polycythemia. But we should remember that the patient is having a desaturation because of shunting. So the actual hemoglobin which is useful to the patient in oxygenated form is lesser than what is actual level in the blood. TOF patients are also susceptible for brain abscesses, and this is because of two effects. One is the increased polycythemia, which causes the infarct in the brain tissue, and further on, some of the infection emboli from the bloodstream, venous bloodstream, they can be shunted from right to left and bypassing the pulmonary filter. So the microorganisms can lodge into the brain and cause abscesses. Most commonly, these abscesses are staphylococcal and fungal. So this is the summary of all the possible areas on which the questions can be asked. They can be asked on cyanotic spells, basic pathophysiology, the X-ray and the ECG picture, or the surgical management of the child. So you can pause over these slides and note down the questions which are commonly asked in the viva, and you should try to make a diagram. Take a minute pause here and try to make a diagram of the pathophysiology of the TOF, which you are going to write in your exam also. So this is the diagram that you have drawn, and this is given in your all of the textbooks, and this diagram represents the pathophysiology. And if you write this diagram, draw this diagram in answer, the examiner is going to be impressed. So guys, this is the summary of tetralogy of Fallows, and there are some additional variants of TOF. There is a pentalogy of Fallows also, where ASD is also associated, and very rarely trilogy of Fallows, where pulmonary stenosis and right ventricular hypertrophy are there, but VSD is not there. Instead, ASD is only there. So these are some of the questions which have been asked in the NEET PG entrance also. In NEET PG, you may be given a case scenario where some intentional error has been done, and you will be asked a question on spotting the error. For example, patient is of cyanotic spell, but on X-ray they give that the lungs are overfilled with fluid, or the ECG shows left axis deviation. So these are the incompatible findings in X-ray and ECG which are not compatible with TOF. So good luck for your preparation with cyanotic heart diseases. I will be making another presentation on transposition physiology, that is TGA. Thank you for watching and stay in touch. And always remember, life is very beautiful as you take it. Thank you.